Welcome, dear friends, to Critical Care Young India Intensivist Sunday webinars. Today's topic is GI bleed, upper GI and lower GI bleed. And the topic for today is our Dr. Vineet Ahuja sir. Sir is a renowned figure in GI, especially in inflammatory bowel disease and related diseases. Sir is Professor of Gastroenterology at All India Institute of Medical Sciences. He's also the Associate Dean for Research in Aiims and has around 200 publications and 25 book chapters. And he's also the editor of Tropical Gastroenterology. So we thank sir for taking time out and sharing his wisdom and knowledge on this platform. Thank you, sir. So we have this lecture from him, and any questions, we will take them at the end. Please feel free to put your questions. So over to you, sir.
Thank you, Tapesh, very much. And I must say it's a pleasure as well as a privilege to be invited on this forum. And I understand this is a very valuable resource for intensivists, critical care people and physicians. And I appreciate the way you have been doing this webinar week after week. Today I'll be talking about GI bleeding, and I'll take you through the concept of GI bleeding. Now, when we talk about the basic agenda for today would be that I'll talk about initial assessment resuscitation, because I think that would be extremely important for all of you. Secondly, then we'll cover upper GI bleed, varicose, non-varicose upper GI bleed. We'll talk about upper GI bleed and anticoagulants. We'll talk about lower GI bleed. And subsequently, in discussion, if required, we can talk about obscure GI bleed. But GI bleed, as this video shows, can be extremely challenging. It is something which can test the nerve of the person who is managing this kind of case. So upper GI bleed, classically, it has been considered, if we talk about location-wise, bleeding with the source is proximal to the ligament of triad. So this is like, for example, the endoscope goes up to D2, D3, and bleeding proximal to the ligament of triad is considered as upper GI bleed. Although now subsequently, I would say that advancements, the way we have been able to assess small bowel with the help of endoscopy and all, now when we talk about GI bleed, classically it was upper and lower. Now we talk about upper, mid and lower. Upper is esophagus to ampulla of Vater. Mid bleed is ampulla of Vater to IC valve, and lower GI bleed is ileocecal area to the anorectum. When do you suspect the upper GI bleed? When the patient has manifestations of either hematemesis or melena. The patient talks about melena, black tarry stool, foul odor, which is a result of acid hemetin, then you know, yes, the patient most likely has an upper GI bleed. Remember that even 60 ml of blood loss can give rise to melena, and melena may persist for 3 days. Another pointer towards upper GI bleed is if on investigations you find that you're confused, the patient has upper GI bleed or not, and if BUN by serum creatinine is more than 30, the ratio is more than 30, then you know that you're dealing possibly with a case of upper GI bleed. Broadly, when we talk about the main causes are peptic ulcer disease, varicose bleed because of portal hypertension, and erosive mucosal disease. The uncommon causes may be malignancies like CS stomach or lymphoma, AV malformation, Gallifloy's ulcer, or hemophilia can be seen uncommon. What about India? In India, what is the commonest cause of bleed? In Western countries, classically it is felt that peptic ulcer is the commonest cause of upper GI bleed. However, when we look at 2 series from India, one from Jammu and another from Aiims, this is Gyan Raut is the first author, and Shalimar's group, when they looked at the upper GI bleed series, they found out that varicose bleed was the commonest cause of upper GI bleed. In fact, around 50% of patients had varicose at least. And if you take into account portal hypertensive gastropathy, as well as GAVE, which is part of portal hypertension at times, then you realize that 50 to 60% of patients would have portal hypertension as the cause of bleed, of which varicose is the commonest. Second commonest would be peptic ulcer disease bleed. After that would be erosive mucosal disease bleed. And then we can have causes like carcinoma stomach or Malrivi's tear or gastrointestinal stromal tumor or dialophysis. So varices remain a very important cause of bleed in our country, and that we should bear in mind. The moment a patient comes to emergency, a quick reconnaissance will give us an idea whether what can be the possible cause. If there's a history of dyspepsia, history of NSAID, and without absence of splenomegaly or no jaundice, you know you're dealing with a possibly a peptic ulcer bleed. However, if the patient gives history of jaundice, has ascites, has presence of splenomegaly, then you know that you're dealing with a patient with varicose bleed. What is the gold standard for making a diagnosis? The gold standard for making a diagnosis is upper GI endoscopy. So the question is how to manage such cases. The fundamental principles are determine the source of bleed, stop the active bleeding, treat the underlying abnormality, and prevent recurrent bleeding. Most important in such cases is immediate assessment and stabilization of the hemodynamic state. So if I convert these four principles into time points, then it would be initial resuscitation, that is the first step. The pre-endoscopic therapy which needs to be planned. And as I told you, endoscopy is the gold standard for diagnosis. So endoscopy and endotherapy would be the third step. And subsequent would be post-endoscopy therapy. So let's go to these four steps for varicose bleed as well as non-varicose bleed. In general, first I'll talk about for upper GI. When you do an initial assessment, you would like to assess the hemodynamic status immediately. If the patient is having a major bleed, you would like to insert two large bore cannulas and start with fluid resuscitation. Early intensive resuscitation is very important. Why? Because it has been shown to significantly decrease mortality. And that is what your objective is. When we talk about fluid resuscitation, unfortunately, there are no randomized controlled trials which are available which have assessed fluid resuscitation in upper GI. You have trials which have assessed fluid resuscitation in sepsis, you have trials which have assessed fluid resuscitation in trauma patients, but in upper GI, we do not have such randomized controlled trials available. So our choices are based on extrapolation of data. The choice of intravenous fluid could be crystalloid or could be a colloid. There is no difference in mortality between a crystalloid or a colloid. However, since crystalloids are easily available, so one goes towards the side of giving crystalloids. Amongst crystalloids, it has been seen that balanced crystalloids, right, like ringer lactate, may be better than saline. Why? Because there could be a lower risk of acute kidney injury and a lower mortality. How much volume would you like to give? The volume would be for crystalloid, replacement volume would be 3 times the blood loss. For colloid, it is equal to the amount of blood loss. But as I told you, colloids are expensive, not easily available. Crystalloids are easily available. So 3 times the blood loss for crystalloid would be the volume to be replenished by with the help of crystalloids. Most important thing, do you run in and get bags of packed RBCs? Do you ask your intern to run in, okay, let's get 4 PRBCs the moment you see a patient with upper GI bleed? No, that's not correct. Because now it has been proven beyond doubt with good, large randomized controlled trials that a restrictive RBC transmission strategy is considered standard of care in non-massive acute GI bleed. If it is a massive acute GI bleed, we're not talking about it. It's a non-massive acute GI bleed. Restrictive RBC transfusion strategy should be preferred. What do we mean by a restrictive strategy? A restrictive strategy says that you should transfuse RBC if you find hemoglobin is 7 grams or below in hemodynamically stable patients, including critical care patients. If the patient has underlying cardiovascular disease, if the patient has previous history of acute coronary syndrome, recent history of acute coronary syndrome, patient is being planned for orthopedic or cardiac surgery, then the threshold can be increased to 8. So in other words, if a patient is stable, then in those cases, if a patient has a hemoglobin of 9, you do not rush into that. No, the threshold is 7. So if the patient has a hemoglobin below 7, only then you rush into give blood in such cases. So RBC transfusion main indications remain when the patient is in hypotension, not responsive to fluids. Secondly, if you find metabolic acidosis, especially lactic acidosis. Why? Because that indicates tissue hypoperfusion. And what is the objective of RBC transfusion? That is to prevent tissue hypoperfusion. Remember that immediate hematocrit may be erroneous because there's loss of both RBCs as well as plasma volume. It takes 4 to 72 hours for hemodilution to occur after blood loss. What should be the guide to volume loss? But in other words, in what ways we can decide that the patient has had a major bleed? If the patient has normal blood pressure, no tachycardia, that means volume loss has been less than 15%. If the patient demonstrates tachycardia or orthostatic hypotension, then it ranges between 15 to 30%. If the patient has supine hypotension, then we are talking about a volume loss of 30 to 40%. And if the patient is in refractory shock, then obviously the volume loss is more than 40%. So this is a simple rule of thumb to decide whether how much volume loss the patient is. Then we would like to stratify. The patient is an emergency. You have taken the blood pressure. You have looked at the pulse rate. You have also examined the patient in terms of whether the patient has a jaundice, splenomegaly, ascites, and all that. Now the question is whether you should admit the patient or not. That is triaging the patient or risk stratifying the patient. There are many scores which are available to look at upper GI bleed, but I think there's one score which is considered better than the other scores, and that is Glasgow-Blatchford score. This really helps to identify which patients with upper GI bleed can be safely discharged. It is based upon two symptoms. The symptoms are melena and syncope. Two findings, that is clinical findings, heart rate and systolic blood pressure. Two basic investigations, hemoglobin and blood urea nitrogen, and two comorbidities, hepatic disease and cardiac failure. And if the score is more than 1, then the chances of rebleed are there. If the score is more than 6, the chances of rebleed are 50%. So you definitely have to admit the patient. However, the score is less than 2 or is between 0 to 1, then the chances of rebleed are minimal. If they are less than 1%, and you can safely discharge the patient with medical therapy. Would you like to put in a nasogastric tube? Nasogastric tube, it has been till now, it has not been, I would say till some years back, it has been considered as the initial mandatory step. That has been that always put a NG tube. Let us see what is the status today. Well, nasogastric intubation may help confirm, but cannot discount suspected upper GI bleed. That is one thing you should be aware. When you put in a NG tube, so if it goes properly, then obviously it goes into the body of the stomach and subsequently the antrum, and the blood loss, if there's any blood loss from the esophagus, from the stomach, or even the first or second part of the duodenum, it would pool out here. And so that blood loss, that blood would come out of the NG tube, and that would confirm that the patient is having upper GI bleed. However, this may not be the case always. As these X-rays show, this is the nasogastric tube which has coiled up somewhere around just below the esophagus. This is a nasogastric tube which has coiled up towards the fundus. This is a nasogastric tube which has not gone into the antrum. There's another nasogastric tube. This, I would still say, is in the correct position, but this nasogastric tube is again not in the correct position. So if you are going to do a gastric lavage or do an aspirate with any one of these three panels where the nasogastric tube is in such a position, then you are going to erroneously label the patient as not having any bleed, whereas the patient could be having a major. Secondly, some people feel that the patient has varicose bleed. You should not put in a nasogastric tube as it may injure the varices and cause more injury. However, that seems to be not true. NG is not contraindicated in varicose bleed. If a IV erythromycin is not available in our country, so nasogastric tube, if it has been inserted, it can give you the advantage of doing a gastric lavage, which can help in preparing the patient for endoscopy. So if I put all the points together, and if you look also at the recent recommendations, these are the European Society of Gastroenterology 2021 recommendations, they're very clear that putting in an NG tube is possibly, they feel it's like something like a torture. They do not recommend the routine use of nasogastric or orogastric aspiration lavage in patients presenting with acute upper GI. But yes, at the same time, I would say there are certain situations where NG is very useful. It not only helps in improving visualization, but it also prevents aspiration. So as of now, you can conclude that nasogastric tube is not mandatory. It is not recommended, except in certain situations where the patient may be having a massive bleed and you want to prevent aspiration, or you want to do a good gastric lavage so that the visualization or endoscopy can be useful. When do you take up the patient for endoscopy? Irrespective of, let us say, the cause or something, overall, there has been again a shift in paradigm. Earlier, the teaching was as soon as the patient comes, the earlier you do endoscopy, that means the higher the chances of saving the patient. Well, it seems the pendulum has swung a little bit because now the recommendations are upper GI endoscopy should be done in 24 hours. Early endoscopy, but not emergent or urgent endoscopy. It should be done in 24 hours after stabilizing the patient in a patient suspected to have GI bleed. However, if the patient has variceal bleed, then in that case, you may do it within 12 hours because the outcomes are better when you do it within 12 hours in a patient suspected to have esophageal or gastric variceal bleed. If the patient has massive bleed, hematophysia is written wrongly out here. The patient has, I would say correctly also it is written, if the patient is having massive bleed, then the patient can manifest with not melena, but may manifest with hematophysia and frank rectal bleed, which can occur if there is a massive upper GI bleed. And along with that, there may be hemodynamic consequences. You do an upper GI as soon as possible because there it makes sense to resuscitate, stabilize the patient, and immediately go for it. So if I conclude all these scenarios, I would say emergent endoscopy less than 6 hours definitely not recommended unless until the patient is really having a very massive. Urgent endoscopy less than 12 hours, best for varicose. Early endoscopy less than 24 hours, best for non-varicose. Delayed endoscopy more than 24 hours is best for low risk stratification. Like I told you about the Glasgow-Blatchford score. So GBS score 0 to 1. You have discharged the patient. You call the patient after a few days for endoscopy, and that is what is known as low risk stratification or a delayed endoscopy. What kind of lab evaluation you would like to do before endoscopy? Complete blood counts, liver function test, kidney function test, INR, and would like to do a venous blood gas for lactate. Anemia with low MCV suggests prior chronic blood loss, and in patients who may be at risk for silent MI, ECG and troponin should be done. If the patient is on antiplatelet agents or anticoagulants, what do you do? How do you decide whether the patient can be taken up for endoscopy? What precautions you would like to take? It's very clear that the patient is on anticoagulants or antiplatelet agents or has an INR which is on the higher side. They cannot be used to define or guide the timing of upper GI endoscopy in patients with acute upper GI. In other words, if the patient is on antiplatelet or anticoagulant and the patient is bleeding and you have to do the upper GI endoscopy within 12 hours, then you would not wait for the effect of antiplatelet or anticoagulant to wear. You would do it within 12 hours or 24 hours as per the indication. Would you like to intubate? That is an endotracheal intubation. Is it a necessity in every patient that acute upper GI bleed? No. Routine prophylactic endotracheal intubation for airway protection prior to upper GI endoscopy is not recommended. In fact, it has been associated with worse outcomes. Yet at the same time, there are certain scenarios where prophylactic endotracheal intubation could be useful. That is if the patient has ongoing active hematemesis where the risk of aspiration could be high. Patient is agitated. The patient has encephalopathy with inability to adequately control the airway. In terms of what pharmacotherapy, the patient is right now, the scenario is patient is lying in emergency. We have assessed the risk. We have taken a history. We have examined the patient. We have assessed the risk, and we have also ordered for blood if blood is required. And at the same time, we have decided what timing of endoscopy would be right for this kind of patient. Now you would like to start some pharmacotherapy. So if the patient has previous history of portal hypertension, you are suspecting variceal bleed, then vasoactive treatment, that is terlipressin or somatostatin or octreotide, should be started as soon as possible. And if you feel that the GI bleed is because of ulcers, then proton pump inhibitor therapy, intravenous therapy should be started without waiting for endoscopic diagnosis. Yet at the same time, what I would say is that different guidelines, there is a little bit of what I would say in terms of they do not fully concur on this. Starting PPI is not considered as a universal recommendation. Why? The reason being that PPI infusion improves visualization, reduces high-risk stigmata and need for endoscopic therapy. But it does not affect mortality. It does not affect risk of bleed, or it does not affect the need for surgery. So PPI, if you are suspecting varicose bleed, then there is no need to start proton pump inhibitor therapy. If you are suspecting ulcer bleed, then you should start proton pump inhibitor therapy. But again, that should not influence the timing of your endoscopy. Now, if the patient is on low dose aspirin monotherapy, what are you going to do before you take up the patient for endoscopy? And the patient is having a bleed. If the patient is on a low dose aspirin monotherapy for primary cardiovascular prophylaxis, you can stop it easily and you can start it later. However, if the patient is on aspirin monotherapy for secondary cardiovascular prophylaxis, if unless until there is a major or a massive bleed, do not stop. And if you have stopped it, you can restart within 3 to 5 days. If the patient is on dual antiplatelet therapy, aspirin plus clopidogrel, you continue aspirin, stop clopidogrel, and again restart as soon as possible, preferably within 5 days. A cardiology consultation would be useful at this stage. A patient is on anticoagulant. If the patient is on direct oral anticoagulants, you stop. They generally they are in the sense that for 12 to 24 hours the action would stay on, but what you can do is you then immediately stop them, so you would stop. If the patient is on vitamin K antagonist, you stop it, and at the same time, if the patient has hemodynamic instability, you would like to administer vitamin K. If prothrombin complex concentrates are available in your hospital, you can give them. They're excellent. They are most useful in this setting. Otherwise, FFPs may be given. What would you do if the patient is on antiplatelet agents? Would you like to, when the patient is having upper GI bleed, do you think this is a case of platelet transfusions? No. Routine platelet transfusion in such a setting is not required. Unless until the patient has thrombocytopenia with platelets below 30,000 something, in case of upper GI bleed, then you may think of platelet transfusion. Tranexamic acid is very popular. Do you think tranexamic acid should be given in every case of upper GI bleed? I think this question has been answered very well with the recent HALT trial which came up, which clearly showed that use of tranexamic acid in patients with acute GI bleed is not recommended. On the other hand, it does not provide any survival benefit. On the other hand, it may lead to increased risk of thromboembolism. So this is a very clear-cut message out here. So while the patient is in emergency ward, what you have done, with the help of a history and examination, you have possibly localized the bleed, whether it is upper GI or lower GI, or possibly mid GI. You have resuscitated the patient with the help of fluids. You have triaged the patient with the help of Glasgow Flash Fold score, whether the patient requires admission or not. You have prepared the patient for endoscopy in terms of using whether the patient, how much blood transfusion the patient requires, as we have talked about restrictive blood transfusion strategy. That is a threshold level of 7 gram% for any normal patient and 8 gram% for any patient with major cardiovascular disease. Subsequently, endoscopy need not be emergent or urgent unless until there is a massive bleed. In case there is a varicose bleed within 12 hours, and in case there is a peptic ulcer bleed within 24 hours, subsequently pharmacological management we have talked about. This is just a table to show you what is the basic difference between varicose bleed and non-varicose bleed conceptual. Varicose bleed is venous, non-varicose bleed is arterial. Even though varicose bleed is venous, but the mortality rates are higher. Why? Because the underlying reserve is poor. The mortality may go up to 30%. In non-varicose bleed, 5 to 10%. PPI is not required in varicose bleed unless until the setting is the patient underwent endoscopic varicose band ligation, came within 3-4 days with a bleed, so you are suspecting post-tibial ulcer. PPI is very much required in non-varicose. Vasoactives are required in varicose bleed. Prokinetics are required in both varicose as well as non-varicose bleed. Antibiotics are required in varicose bleed, but not in non-varicose bleed. Platelet transfusion are not required unless under the platelet counts are low. And the range INR, if it is there, that is not a contraindication for endoscopy in varicose bleed. So the message out here, what I want to give is that if you have a hammer, you've got so many kind of techniques which are available today. You've got so many different kinds of pharmacotherapy available today. So would you like to use all of them? If you have a hammer, if you think your only tool is a hammer, every problem starts looking like a nail. And that is what last decade has taught us when it comes to basic principles of upper GI bleed. That is, earlier NG tube was mandatory in every case. No, it is not in every case. In fact, it is not recommended for most cases. Aggressive blood transfusion was a bail, but no, restrictive strategy clearly improves outcomes and improves mortality. Emergent endoscopy, no, that leads to higher mortality because you end up with more complications if you have not stabilized the patient. You need not stop all antiplatelets and push the patient for a cardiovascular event. Aspirin can be continued if the patient is on secondary prophylaxis. Give high dose PPI in all cases. Yes, in cases suspected to have ulcer bleed, but not in cases suspected to have varicose. So with this, now I move on to specifics of varicose bleed after I've given you a broad idea about general principles. When we talk about varicose bleed, as you all know, varices can be there in the esophagus. Besides that, these are the typical esophageal varices, which is the commonest site of varix. And besides that, also you can have varices around the gastroesophageal junction, which are known as the GE1 and GEV2. And besides that, you have the fundal varices, which are known as isolated gastric varices, or you can also have other ectopic varices. So although esophageal varices are prominent, but the isolated gastric varices or fundal varices are famous or notorious, I would say, for torrential bleeding. Simple definition of what you would call as a high-risk varix is something which has a high risk of bleeding, that is the high-grade varices. High-grade varices, they are more than 5 millimeter in size. For gastric varix, we take a cutoff of 10 millimeter. They have a high risk of bleeding. Any varix with a red color sign, any size varix in, let us say, child hook, say class C. We'll talk about child hook class C further on. Low-grade varices are all other varices. Why this is important? Because low-grade varices, the prognosis would be better, the risk of bleeding, rebleed would be less. Whereas with high-grade varices, you need to be very, very vigilant and very, very aggressive. And varices, besides that, as I told you, fundal varices are notorious for torrential bleed, and you can have ectopic varices, which can be really troublesome, like rectal varices or colonic varices. So actually, varices can be anywhere. Another thing which you have to understand is that when we talk about portal hypertension and varix, so varix by itself tells you that the portal that is the portal hypertension has reached at a higher level. How do we measure portal hypertension? We measure portal hypertension by hepatic venous pressure gradient. So a hepatic venous pressure gradient, when it is more than 5 millimeters, the patient is said to have portal hypertension. When it is more than 10 millimeters, the patient is said to have clinically significant portal hypertension. And subsequently, after this stage, the varices start developing, and the patient, the liver may also decompensate. More than 12 millimeters of mercury, the patient may have an acute variceal bleed, and 20 millimeters of mercury or more, the patient is going to have a bad prognosis with very high mortality. Why I have put up this slide out here? I have put up this slide out here for you to understand that one of the major determinants of bleed is hepatic venous pressure gradient. So if you use agents which decrease the hepatic venous pressure gradient, or if you use it as an outcome variable, then your outcomes would be really good. There are two scores you should be aware of. That is, when you're managing liver diseases with variceal bleed or any liver disease, it's a very famous score, Child-Turcotte-Cook score, and it is also a very easy score where you do not need any calculator or anything to get the score out of this table. It is based on basically 5 factors: encephalopathy, ascites, bilirubin, albumin, and the prolonged prothrombin time. And so give 1, 2, or 3 points depending upon whether the patient has no ascites or mild ascites or severe ascites. So class A is if there are less than 6 points, that is the best, least severe liver disease. Class B is when there are 7 to 9 points, moderately severe liver disease, and class C is 10 to 15 points, most severe liver disease. And over, I would say, 3 to 4 decades, this score has stood the test of time. In other words, this remains a very easy bedside score by which you can decide whether the patient is going to do well or not. Child Cook C or Child Cook scores class C, the patients are going to have very bad prognosis as compared to patients who are child class A. Child class A, the patients do very well. Another score which has come up is, which is known as the end-stage liver disease score, that is a MELD score from the Mayo Clinic, which takes into account 3 factors: bilirubin and INR and creatine. Here you need a app or a calculator to calculate it because it is based on a regression equation. And there is another score which subsequently has come up, which is known as MELD sodium, which is bilirubin and INR and creatine and sodium. Based on these four factors, this score is very useful for triaging again patients who have not only have severe liver disease, but also to refer for liver transplant. Anybody with a MELD score more than 19 or MELD sodium more than 23 is somebody is a patient who should be the planned for liver transplant. Now, which among these patients are the sickest? If a patient comes with variceal bleed, if the patient has child class C, or he has a high MELD score, failure to achieve primary hemostasis with endoscopy, then these three variables have been consistently found to predict 6-week mortality. This information should be very useful for all of you because the moment a patient comes and if you can triage the patient in terms of calculating the child class, in terms of calculating MELD score, and you also know whether the patient, how the patient responded to endoscopy, you know what is the further course for this patient is going to be. Where are you going to manage such patients? Patients with acute variceal bleed should be managed in intensive or intermediate care units. Why? Because they have a high mortality. The mortality of variceal bleed is still 20-30%. Which drugs you would like to give? You would like to start, even when you're suspecting variceal bleed and it has not been confirmed, you would like to start splanchnic vasoconstrictors, that is the terlipressin, somatostatin, or octreotide. Why? Because these splanchnic vasoconstrictors, there is increase in flow and portal hypertension, and you use vasoconstrictors to decrease that flow. And once they are started, they should be continued for 2 to 5 days. Do not stop them immediately after endoscopy. The agents you can use terlipressin, you can start with 1 milligram, and ideal dose should be 2 milligram every 4 hourly. Somatostatin, a bolus dose of 250 micrograms is given IV, followed by 250 microgram every hourly, or the dose can be stepped up to even 500 microgram. Octreotide, the dose is 550 microgram bolus dose, followed by 50 microgram every hour. Remember that in patients who are on terlipressin, hyponatremia has been described. And this also occurs mostly occurs in patients who have preserved liver function. Therefore, sodium levels should be monitored. What about proton pump inhibitors? That is again a knee-jerk response. If a patient with bleed has come, any case of bleed, proton pump inhibitors would be useful. No. Proton pump inhibitors, when started before endoscopy, should be stopped immediately after the procedure, which confirms that there is a variceal bleed, unless and until there's a strict indication to continue them. The strict indication could be, let us say, the patient has an associated ulcer, or this patient has a post-EVL ulcer, then in that case, we may continue them. Otherwise, proton pump inhibitors should be stopped. All patients with variceal bleed should receive prophylactic antibiotics. That should be an integral part of therapy for patients with cirrhosis presenting with upper GI bleed and should be instituted from admission. Should it be given even in very stable cirrhosis? Child Bourget, as we talked about, this the stablest level of cirrhosis. So there, it has been seen that even though the risk of bacterial infection and mortality is very low in patients with child Bourget cirrhosis, but it is not clear yet if it can be avoided in this subgroup. So better to treat even child class A with prophylactic antibiotics in cases with variceal bleed. Which antibiotic? Generally, the antibiotic which is used is intravenous ceftriaxone, 1 gram every 24 hours. That is the dose which is used, and it is given for 5 to 7 days. If the patient even has low-grade varices still, and the patient but however has bled, the patient should be given intravenous ceftriaxone 1 gram for 24 hours. Why? Because this is a prophylactic dose in terms of preventing spontaneous bacterial peritonitis, which may occur in 20% of these patients. And why do you want to prevent spontaneous bacterial peritonitis? Because SBP has a very high mortality. What is the timing of endoscopy in variceal bleed? You have started vasoactive drugs, you have stopped PPIs, you have started antibiotics. When are you going to do an endoscopy? Endoscopy should be done in all cases, but after resuscitation and within 12 hours of presentation. If the patient is very unstable, then endoscopy may be performed as soon as safely possible. When an endoscopy is done, there are many techniques to control or to take care of the varices, but the technique which is considered to be most effective is endoscopic variceal ligation, known as EVL or EBL, endoscopic band ligation, whereby bands are put over the varices. As a result, the varix gets sloughed off, and this is a recommended form of endoscopic therapy for acute esophageal varices bleed. What about gastric varices? Gastric varices, we do not do varicose ligation. You would like to put in tissue adhesive, something like butyl cyanoacrylate. That is recommended, for example, in a patient with isolated gastric varices or type 2 gastric varices. Now here butyl cyanoacrylate has been put, and if you take an X-ray after that, in fact, what you can, if you mix it with the cord oil, you'll be able to see the feeding vessel as well as the varices where the obturation has happened. All patients with varicose bleed, if they have not had a recent imaging, should be imaged also subsequently. They should undergo a contrast enhanced cross-sectional imaging, CT or MRI. That is done because we want to rule out hepatocellular carcinoma. We want to rule out splanchnic vein thrombosis and also to map out photosystemic collaterals which can guide further treatment. All these recommendations have come up recently in last 6 months. They are part of the Vino 7 consensus document which has come. In patients with varicose bleed, another thing to be added is that you would like to add lactulose orally or lactulose anyway. Why? Because you want rapid removal of blood. If blood remains, then obviously it is going to get converted to nitrogen and ammonia. So that will lead to hepatic encephalopathy. So lactulose should be started in all patients with acute varicose bleed. When you're going to check coagulation status, the traditional teaching has been that, okay, do a PT, INR or APT. But remember that in cirrhosis, PT, INR do not accurately reflect the hemostasis status of patients with advanced liver diseases. In fact, for that, the best technique is thromboelastography. This is another study by Gyandeep and Shalimar, where they show that when you measure the coagulation parameters on the basis of thromboelastography, you find that transfusions are much less, the need for transfusions is much less as compared to conventional transfusion, conventional transfusion group. At the same time, there is a similar control of bleeding, suggesting that thromboelastography, which is available at most centers, would be the best way to monitor coagulopathy or coagulation status. Next thing you have to remember that do not just go in terms of correcting coagulation parameters too much. Don't go overboard. Why? The logic is that varicose bleed is due to portal hypertension. And the aim of treatment should be focused on lowering portal pressure rather than correcting coagulation. You have to lower portal pressure. As I told you in a figure before this, that HVPG is a major determinant. Underlying liver disease status is a major determinant. So HVPG you would like to reduce. Underlying liver status, if you can improve, in other words, can you improve the child score? Can you improve the MELD score? That would be important. Third thing is if you can achieve hemostasis. So should FFP's fresh frozen plasma be transfused? No. In acute varicose bleed, transfusion of fresh frozen plasma is not recommended, as it will not correct coagulopathy, and in fact, it may lead to volume overload and worsening of portal hypertension. So again, as we talked about restrictive transfusion strategy, similarly for FFP, be very clear that it is not recommended. Should platelets be transfused? Again, in the setting of acute varicose bleed, there is no evidence that platelet count and fibrinogen levels, they correlate with the risk of failure to control bleeding or even rebleeding. Hence, the decision to correct to the platelets should be considered on a case-by-case basis, particularly if the patient has thrombocytopenia, platelet count less than 50,000 or less than 30,000 patients continue to bleed, there you may think of. Otherwise, in every case, no, they should not be transfused. Very interesting thing that you would like to start oral nutrition as fast as possible for two reasons. Malnutrition increases the risk of adverse outcomes. Secondly, enteral nutrition also decreases the stress ulcer bleed rates when the patient is in ICU and also decreases the chances of developing an infection. So oral nutrition with liquid should be started as soon as possible. Now let's talk about 2 or 3 modalities which you should be aware of. That is, if the patient has gone endotherapy, however, if the patient continues to bleed, what are the other new alternatives we have? The foremost is what is known as transtubular intrahepatic photosystemic shunt, TIPS, as it is very famously known as. What is TIPS? It is done by an interventional radiologist, whereby you place a stent through the percutaneous tube, which connects the hepatic vein to the portal. The moment this kind of stent is placed, 3 tips in the portal vein, there is a lot of increased pressure out here. So once there is an outflow, the portal pressure decreases. As a result, what happens is obviously the bleed at the repeat rates, they go down. So this is what is the principle of TIPS, and this is done commonly at most centers across the country. Another intervention radiology procedure which is mainly used in gastroesophageal gastric varices is BRT. BRTO is balloon occluded retrograde transvenous obliteration. Again, percutaneously, you gain access to the renal vein, and subsequently, what you do is that you obturate the vein which is feeding the collaterals out there with the help of glue or with the help of coils, and as a result, you inflate a balloon, and subsequently, you can also put in coils out there. As a result, that channel is blocked, which leads to decrease in the varicose size. Third is an endoscopy procedure, which is done in cases of refractory bleed, that is putting in a SEMS, self-expandable metal stent, which is known as the Ella-Dennis stent. So this is a Ella-Dennis stent, which is being placed. The stent is placed in the esophagus, the stent expands, and the stent expands, and as a result, it puts pressure on the esophageal varices, so the bleed stops. Once it puts pressure on the esophageal varices, the bleed stops. After a few days, the stent can be retrieved, pulled down. Then we have the time-hold method, that is mechanical tamponade with the help of Sengstaken Blackmore tube. So there are three modifications available: Sengstaken Blackmore tube, which is an esophageal balloon and a gastric balloon; a Minnesota tube, which has 4 lumens; a Linton-Nicholas tube, which has only a gastric balloon. So you have Sengstaken Blackmore tube, whereby you have a gastric lumen, whereby aspirate the gastric lumen, you put the tube into the stomach, thereby you subsequently pull the tube, and while inflating the gastric balloon with the help of 250-300 ml of air or fluid, and as a result, what happens is it puts pressure on the perforating vessels out there, and the bleed may stop. You can also inflate the esophageal balloon. But balloon tamponade has gradually not been used so commonly. The reason being it would be, I think, we best use in the periphery areas where facilities for endoscopy are not there at all. Why? Because balloon tamponade has been associated with not only major discomfort but also adverse effects. So Daricella stent is also a kind of mechanical tamponade, but can be used for up to 7 days. Balloon tamponade not more than 24 hours. SEMS is comfortable for the patient. Balloon tamponade is uncomfortable for the patient. SEMS, the patient can undergo endoscopy, allows oral feeding. Balloon tamponade, all this is not possible. SEMS, there are lesser chances of aspiration or esophageal perforation, and SEMS is more costly. And as I told you, balloon tamponade would be good for areas where the resources are heavily limited. So there it still remains as a fallback option when patient does not respond to any kind of therapy. Now for refractory bleed, so these are the 4 or 5 options which I have told you, which are there in patients with refractory bleed. So what is the first choice? In good best centers for refractory bleed, the first choice is TIPS. Failure to control varicose bleed despite combined pharmacological endoscopic therapy, best managed by a covered TIPS, that is known as salvage TIPS. Another procedure is preemptive TIPS. Salvage TIPS is if you're not able to control bleed despite pharmacotherapy and endotherapy. Pre-endotherapy is if you feel that the patient has a very high chance of rebleed. You do not want to wait for the rebleed to occur. Then you put a TIPS before that, that is known as preemptive TIPS. Preemptive TIPS is ideally put in within 24 hours or best within 3 days after the first bleed. In which patients do you put it? Where the child cook class is between 7 to 14. In other words, the patients are not extremely sick. On the other hand, the patients are not, where the liver reserve is not so well maintained as in child class A. So intermediate category, there if the patient has active bleed at initial endoscopy or HVPG is more than 20 at the time of hemorrhage, if the patient can afford, then preemptive TIPS has become the standard of care. As I told you earlier, HVPG more than 20 is a determinant of bad prognosis. Active bleed at initial endoscopy is a determinant of bad prognosis. Child book class C higher scores are a determinant of bad prognosis. So if you have a case where the prognostic factors are bad, patient has bled once, then subsequently if you can do a preemptive TIPS, the results are better. Even if the patient has acute on chronic liver failure or hepatic encephalopathy at admission or hyperbilirubinemia, then also it has been advised that preemptive TIPS can be done. These are not contraindications for putting in TIPS. But when not to do TIPS? what is known as futile tips, that you have the patient undergo such a procedure, and there's an expensive procedure, still the patient does not benefit. That is, if the patient is extremely sick. We said that child poke dictates the outcomes. But after a certain time, that is when the child poke score is more than 14, that is the 15, that 15 is the highest level which it can reach, then in those cases, the reserves of liver are so bad that doing any kind of maneuver at that point of time will not lead to good outcomes. So it may be futile. If the MELD score is very high, more than 30, that means there are no liver reserves. If the lactate is more than 12, unless and until that you're planning liver transplantation within a week or something, it is envisioned in the short term, and you want a bridge, short-term bridge there you may do a tips and send the patient for liver. Then refractory bleed, as I told you, in resource constrained areas, mechanical tamponade still remains the best choice, and mechanical tamponade with the help of balloon tamponade. In tertiary hospitals, now mechanical tamponade with the help of self-expandable metal stent is being done rather than balloon because of the adverse events associated with balloon tamponade. Both are as efficacious, and SENS is a more safer option. And in patients who have refractory bleed because of gastric varices, they are BRTO, as I told you, balloon occlusion of retrograde obliteration of the gastric veins is done, and that can be done. So if I would summarize acute variceal bleed current status, vasoactive, yes, in all cases, 2 to 5 days. Terlipressin, somatostatin, octreotide. Terlipressin has been associated with the best survival rates, but at the same time, terlipressin has been associated with more adverse events compared to somatostatin or octreotide. Antibiotic prophylaxis, ceftriaxone, 1 gram for 24 hours for 5 to 7 days, yes. PPIs are not required. Endoscopy can be done early on within 12 hours. EVL, endoscopic variceal ligation, is the best modality of hemostasis. Give lactulose so as to prevent hepatic encephalopathy. Prophylactic fresh frozen plasma not required. Platelet-rich plasma not required. Oral nutrition start early. You may do a salvage tips for refractory bleeds, and for patients who have a higher risk of re-bleed, you may do a preemptive tips. Otherwise, for refractory bleeds, you can do put in a Danicella stent, that is a self-expanding metal stent, or a balloon tamponade with the help of Blackmore, Minnesota Blackmore tube can be done. And gastric variceal bleed, first line therapy is cyanoacrylate blue injection and BRTO if refractory. Now let me move on to non-variceal bleed. Again, timing of endoscopy. Here, timing of endoscopy is considered as early endoscopy within 24 hours of presentation. That is, resuscitate the patient and then going forward. Once you do an endoscopy, why is endoscopy very useful? Because in endoscopy, you grade the ulcer. If you find an ulcer, you grade the ulcer, peptic ulcer, gastric ulcer, duodenal ulcer on the basis of a forest class classification. Like it has class 1A, where there is an active spurter. Class 1B, where there is active ooze. Class 2 is where you may find a visible vessel. Class 3B is an adherent clot. Class 2C is pigmented spot. Class 3 is just a clean vessel. So why are we talking about all these classes? Because the moment you characterize an ulcer in one of these classes, then you know that what is the chance of rebleed, or in other words, which are the patients which should be taken up for therapy then and there when the patient is undergoing endoscopy. If the patient has a spurter or an active ooze or a visible vessel, then the chances of rebleed are high, and the patient should be definitely taken up for endotherapy. However, if the patient is 2C, ulcer with a hematin spot or a clean based ulcer, then in last two categories, it means the chances of rebleed are low, and in fact, patient can be discharged after observation. Whereas the first three classes, the cases, the patient has to be definitely admitted. And you have to also look for other predictors of rebleed. One is obviously the forest class we have talked about. The other is hemodynamic instability, comorbid illnesses, active bleeding not controlled on endoscopy, large ulcer, posterior duodenal ulcer, or a lesser curved gastric ulcer. How do you manage it? I'll not go into details of it, but you should know that it can be the endoscopic management tools contain injection therapy with the help of adrenaline, thermal coagulation with the help of heater probe, bipolar, monopolar probe, or you even have clips which you can apply through the scope, over the scope, or you have hemostatic probe. For example, A simple epinephrine injection, which is diluted 1:10,000 or 1:20,000, is injected on the periphery of the ulcer. What you see out here is the vessel of the ulcer, which can rupture any time. And this is the base of the ulcer. These are the edematous folds around. So what you can do is you can inject. Once you inject, it has a tamponade effect on the vessel. And as a result, the chances of the rupture of the vessel and the bleed, they significantly decrease. And this is how you see how the vessel has shrunk down. And this is how this therapy is effective. Similarly, you have argon plasma coagulation, whereby with the help of coagulative necrosis, you can burn the ulcer. And if the patient is having, let's say this is a bleeder which is there, then this is actually an ampulla, the side of the ampulla, there is bleed which is going on. And what you find here is argon plasma coagulation is applied, the area is post coagulative necrosis, and as a result, the bleed stops. Then you have clips, the clips which can be applied around the ulcer base of the artery. This is an artery, there's a breach in the mucosa, and there's a non-bleeding visible vessel which can be seen. This is the ulcer base. And if clips are applied on the artery, what happens is, as a result, the chances of rebleed obviously go down because that area gets occluded. If there are very large vessels, very large ulcers, then you can put over the scope clips, which are much larger than the regular clips. So the question is which modality to use. Remember that just epinephrine injection is no longer used as monotherapy. At least two modalities should be used, that you would combine epinephrine injection with a heater probe, or you would combine epinephrine injection with a clip or something like that. Now coming to management in the ICU. High dose PPI therapy has to be given after endoscopic hemostasis. How many days? 3 days. Even if you have had a successful endoscopic hemostatic therapy. Why? Because you want to maintain the pH over 6. If you do not maintain the pH over 6, then the chances of the chance of rebleed would be higher. What is meant by high dose PPI therapy? 80 milligram bolus followed by either a 8 milligram per hour infusion for 72 hours. Other protocol can be 80 milligram bolus followed by 40 milligrams every 12 hours intravenously. Intermittent oral or intravenous therapy is uncertain, although basic thing is what I would say is that one of the two protocols can be used, where you give 80 milligram bolus followed by 8 milligram per hour infusion for 72 hours, or 80 milligram bolus followed by 40 milligram every 12 hours intravenous. Remember that if the patient has active bleeding of visible vessel where the chances of rebleed are high, or the patient has an adherent coat where again the chances of rebleed are high, even if you do not do an endoscopic therapy, still in both these cases, high dose PPI therapy has to be given. It's only in forest class 2C or 3 where we talked about a clean base or a flat pipetted spot, where we said that, okay, the chances of rebleed are low, where you do not need to do any endoscopic therapy, and you can send the patient home on oral therapy. There you would like to give standard PPI therapy. At discharge, you would continue on twice daily PPI therapy until 2 weeks at least after index endoscopy, and thereafter you can decide on once a week PPI therapy. H. pylori testing can be done during the first endoscopy only. Although eradication therapy, there is no need to start it immediately, can be started subsequently, but it should be definitely given if the patient is found to have positive H. pylori. What if the patient continues to bleed after even one successful endoscopic hemostatic therapy? You go back in again, you go and repeat the endoscopy, and if the patient's bleed gets controlled with the repeat endoscopy, fine. Otherwise, the patient is either goes in for transcatheter arterial embolization, or the patient goes in for surgery. So this is a meta-analysis that shows that transcatheter arterial embolization, which is done by interventional radiologists, when it was compared with surgery, it's a viable option for first-line therapy for refractory non-varicose bleed. So to summarize, the learning points of non-varicose bleed is upper GI endoscopy in 24 hours. No need for urgent endoscopy within 6 hours. These are options to be exercised only in case-to-case basis for urgent endoscopy when the patient is hemodynamically unstable. You have been able to stabilize the patient to some extent, and you want a quick endoscopy. Otherwise, in 90% of the cases, I would say more than that, stabilize the patient, endoscopy in 24 hours. Look at forest class, because that would decide endotherapy requirement and the chances for rebleed. Two modalities of endotherapy preferable. Do not only use epinephrine injection. High dose IV proton pump therapy for 3 days. Relook endoscopy is not required. However, if the patient has a rebleed, then you can repeat the endotherapy and endoscopy. If the patient is refractory to endotherapy, then the choices are transcatheter, intravenous, intraarterial embolization, or surgery. Just a few slides on patients who come with anticoagulants. Again, like for example, 37-year-old lady diagnosed case of deep vein thrombosis for a year on anticoagulation warfarin, develops upper GI. What are you going to do about warfarin? Are you going to stop it? INR is 5. Can the patient be taken up for upper GI endoscopy? If we stop warfarin, what is going to happen? Another case, 75-year-old lady with diabetes mellitus and hypertension, atrial fibrillation, history of stroke just 2 months back, on anticoagulation with warfarin. She develops upper GI bleed with shock. What are you going to do about anticoagulation? Clearly, when the patient is on warfarin, that is a vitamin K antagonist, you would like to reverse the effect if the patient is having major. How do you do it? Give a vitamin K. It takes 24 hours to correct iron. You have the option of giving fresh frozen plasma. It requires 9 hours for complete reversal, right? The dose uses 15 ml per kg. So 3 to 4 units for a 70 kg attack. Or you can give prothrombin complex concentrate, 3-factor or 4-factor, but that is not available at many centers. Factor 7A has no role in such cases. So the best therapy would be to give PCC because you don't need to check patient's blood group, very fast onset of action, less risk of volume overload, but then availability remains an issue. Timing of endoscopy, remember that supratherapeutic levels of INR does not mean that you need to wait for correction of coagulopathy and delay endoscopy. Do not do that. So acute bleeding, resuscitation, if the patient is in a shock, stop warfarin, give injection vitamin K or PCC, subsequently go in for upper GI therapy, significant bleed without shock, stop warfarin, injection vitamin K given over 3 months, and subsequently repeat INR and go in. Minor bleed, you don't need to give anything except by oral vitamin K. If the patient has been on direct oral acting anticoagulants, then you need to stop it and go in for endoscopy, whether the patient is with shock or the patient is also having active bleed. The specific antidotes are only available in case of dabigatran, otherwise apixaban, which is the least, which is generally given in patients who have a chance of GI bleed because it has the least chances of GI bleed, or it's the least frequency of GI bleed. There we do not have an antidote. So in the first case, 37-year-old lady, DVT for more than 1 year on warfarin, the low risk of thromboembolic event. So stop warfarin. Clinically significant bleed, give vitamin K, give PCC or fresh frozen plasma and go ahead with endoscopy. Non-significant bleed, injection vitamin K, INR less than 2.5, then it is considered as a safe INR. Again, if there's a major bleed, you have to go sometimes with the INR more than 2.5. But if given a chance, the cutoff for ulcer bleed would be INR less than 2.5. For varicose bleed, there is no cutoff. Even in supratherapeutic INR, you have to do it. The second case, the other case was 75-year-old lady with atrial fibrillation. Obviously, the risk of thromboembolic event is very high. To stop warfarin, give vitamin K, PCC or FFP, and subsequently perform therapeutic endoscopy, but start unfractionated heparin in prophylactic doses. Right? And if the patient, let us say, is on aspirin or clopidogrel, what do? Clinically significant bleed. If the risk for ischemic event is high, that is a bare metal stent less than 1 month, drug-eluted metal stent less than 12 months, or is acute coronary syndrome or MI in last 90 days, then your chances of adverse event are very high. So you would like to continue both aspirin and clopidogrel. However, if these three are not there, then you can stop clopidogrel and subsequently go on and perform therapeutic endoscopy. Now, what about a patient who is admitted in intensive care and there is a chance of developing stress also? What do you do in such a setting? What are the conditions which give rise to this situation? That is, if the patient is on mechanical ventilation for more than 48 hours, then there's a chance that the patient may develop stress ulcer and the risk of bleeding is there. If the patient is not on enteral feeds, if there's a previous history of peptic ulcer disease, or if the patient is on antiplatelet agents, how do you prevent stress ulcer bleed? Now, this is a very tricky question because I believe the best answer for that is to give enteral feeds. Otherwise, PPIs may prevent it, may not prevent it. The data is not very clear. PPIs or H2RAs in high-risk groups can be given to prevent stress ulcer bleed, but not in every case. What about the risk of pneumonia with PPI? It seems that both PPIs and H2RAs have an equal risk of pneumonia in such a setting. So in high-risk groups, you would like to give PPIs or H2RAs. But remember, if you can put the patient on enteral feed, that may be the best way to counter stress ulcer and the bleeding risk.
Thank you very much for that wonderful update and exhaustive talk on upper GI bleed. And sir, just to go through certain points, first of all, about blood urea to creatinine ratio. So blood urea to creatinine ratio is elevated in upper GI bleed only, or as well as lower GI bleed. And what is the cause for this elevation, for steroid elevation?
Wherever there is degradation of hematin, that leads to elevation of blood urea. So the degradation of hematin occurs in the small intestine. So in upper GI bleed or upper mid small intestinal bleed, you will have blood urea elevated, blood urea by creatinine ratio elevated. In lower GI bleed, you will not find this kind of effect.
It is the degradation of hematin, sir, not elevation, absorption of urea or the proteins of the protein.
No, it is not.
Okay, sir. So then coming to the next question, how is the HBPG calculated actually? And is it
HVPG is that you put in a catheter transfemorally, or you can also put it intrajugularly, intrajugular vein or transjugularly. So what happens is that you occlude the hepatic vein out there and calculate the difference between the free pressure and the occluded pressure. If the HVPG, if it is more than 5, that suggests that the patient has portal hypertension. If HVPG is more than 10, that suggests the patient has clinically significant portal hypertension. If HVPG is more than 12, then the chances of varicose bleed are there. If HVPG is more than 20, then the chances of refractory varicose bleed. Right. So that way HVPG is an excellent guide, and so you can monitor HVPG regularly also, although it remains a invasive procedure by which you monitor it. You cannot monitor it non-invasively. You have to put in a catheter.
Is this research tool, sir, or is it used clinically also? Are we using it clinically, or is it?
It is used clinically in tertiary hospitals. It cannot be used regularly.
Okay, sir. So then coming to this, you had said that the patient is on antiplatelets. We should not be transfusing platelets. If they start bleeding. So is there any evidence on this, or is this an expert opinion, sir? Because this applies to other situations also.
So the evidence is very much there that unless until the patient has thrombocytopenia to the tune of 30,000 or 50,000, and the patient is having a bleed, then only you would like to transfuse. Otherwise, in cirrhotics, as it is, the patients have thrombocytopenia. So there is no point transfusing platelets because you are not correcting the coagulopathy, is not going to stop the bleed. It is the underlying portal pressure which needs to be corrected, or the underlying liver status which needs to be improved. That will only lead to more volume decomposition in the form of volume overload of all.
Okay. So then coming to the resuscitation, if the patient is in hypotension, obviously you will give blood. But there are situations where there's no hypotension and there's no acute deterioration, and you have to give, obviously you cannot give them enterally. So you have to give them maintenance fluids. And you had said ringer lactate, and we of course use ringer lactate. But how much to give, sir? Because you do not want to give too much also. So what parameters can we use?
So parameters it can be using, one is it is 3 times the blood loss. Other is that if the patient has normal heart rate, no tachycardia, no hypotension, so there has been less than 15% of blood loss has been there. If the patient has orthostatic hypotension or tachycardia, then it is around 20% or something. If the patient has hypotension, which is a supine hypotension, then it is 30%. So based on these parameters, you may calculate, but you do not want, again, aggressive fluid resuscitation. You would like optimal fluid resuscitation. As we talked about restrictive blood transfusion strategy, similarly, fluid resuscitation has also to be optimal rather than aggressive.
So then other thing is, the guidelines say that endoscopy should be done within 24 hours or maximum 12 hours. But supposing, I only want to understand here that if the patient is not stable, bleeding, spurting, why don't we go in early with endoscopy, even earlier, immediate kinds?
So earlier at all centers and urgent endoscopy was done because it was thought that endoscopy is a tool by which not only you can visualize the site where bleeding is happening, but also stop it. It was an opportunity to do so. But what was seen is that the complication rate was much higher if the patient had not been stabilized. So the chances of aspiration would be there. Moreover, emergency endoscopy done at late night settings, emergency settings, the proper teams would not be there. Endoscopy being done in hypotensive individuals would lead to other complications. So it has been seen that if you stabilize the patient, that is much more important. Similarly, for colonoscopy, if you do a colonoscopy without the preparation, then the chances of picking up the lesion are very less. So you need that much time to prepare the patient. So those are the reasons why, unless until the patient is very unstable and you do not know what your options are very limited, you would like to stabilize the patient. Then so you have already started pharmacotherapy, and then subsequently you would do an endoscopy, not too delayed also, but yes, within 12 hours of varicose bleed, within 24 hours for peptic ulcer.
Right, sir. So then you had said about the prophylaxis after varicose bleed with ceftriaxone. So is ceftriaxone still the drug, sir, or should we use a higher antibiotic?
No, still the drug. That's a prophylactic therapy. That is still the drug.
Okay. So only
in fact, for spontaneous bacterial peritonitis, also the first line therapy which we use is still ceftriaxone. Although the dose out there would be not 1 gram 24 hours, but at least 2 to 3 grams.
Okay, sir. So, I was only asking in view of increasing resistance because ceftriaxone came in quite a few years ago. It still works. It still works. Right. So then about erosive mucosal disease. Can you just elaborate a little on the, because this is very important to us because patients on the ventilator and all, they're critically ill. So just a little bit about physiology about erosive mucosal disease, sir. How exactly, a patient on the ventilators and critically ill, how do we actually get this erosive mucosal disease?
If the patient, let us say, has erosive mucosal disease can occur because of NSAIDs. It can occur if the patient has a coagulopathy. It can occur if the patient has a chronic renal failure. Patient is on hemodialysis or something. It can occur if the patient is on antiplatelet agents. So in such a setting, whenever there are erosions which are there, those erosions generally lead to coffee ground vomitus or a slow ooze. It is not a major bleed which happens. So to stop that, what you can do is either you can have coating agents like sucralfate, or you can give H2RAs. The H2RA antagonists as well as PPIs are equally effective in this setting. If the patient erosive mucosal disease can lead on to stress ulceration also, which can occur if the patient is on ventilator for more than 48 hours. Right? So in all these settings, ventilator for more than 48 hours, not on any enteral feeds, chronic renal failure, patient earlier on NSAIDs, patient on, because let's say rheumatoid arthritis, osteoarthritis, patient on NSAIDs, then patient on antiplatelet agents, patient on aspirin. All these are situations where erosive mucosal disease can. So in such a setting, when erosive mucosal disease develops, then you can give a coating agent like sucralfate. That is not in the ICU, I'm talking about outside the ICU. If the patient is in ICU, then they develop stress ulcers rather than erosive mucosal disease. Erosive mucosal disease is a diagnosis of few patients who come with mild anemia, mild abdominal pain, and we see them in an OPD setting. In an ICU setting, you would see stress ulcers. So there, if patient is on stress ulcers, you would give PPI, H2RAs, you would like to start enteral nutrition. If a patient has erosive mucosal disease bleed, you will do an endoscopy, diagnose it as erosive mucosal disease bleed, and give either sucralfate or you will again give PPI or H2RAs and try to take off the offending agent.
Right. So the PPI of dosing would be what, sir? OD, pantoside OD would be okay for stress ulceration?
So pantoprazole can be given like initially, like if there's a bleed, then high dose IV therapy is required, 80 milligram bolus followed by 8 milligram per kg for 3 days, or 80 milligram bolus followed by 40 milligram BD for 3 days. If the patient has, let us say, no bleed, just stress ulceration, then in that case, a single dose of proton pump inhibitor or a double dose of proton pump inhibitor therapy should be sufficient initially, but remember that a double dose of proton pump inhibitor therapy would lead to a higher risk of pneumonia or infection. So preferable to give a single dose of proton pump inhibitor.
Right, sir. So then coming to the PPI of choice for ulcer bleeds, peptic ulcer bleeds, is there any choice of PPI or anything can be substituted in equivalent doses?
So whichever intravenous is available, they are same.
They are all the same. Okay, sir. So if there are any questions from the, thank you, sir. If there are any questions from the audience, any questions, anybody, please? So I think there are no questions, sir.
Okay.
Thank you very much, sir, for
Thank
the
you.
time and the details and teaching all of us. Thank you very much. And thank the audience.
It was a slightly long lecture, but there were so many things to be covered. So
No. We thank you, sir, for speaking for so long. It is exhaustive more for you, and we actually enjoyed it. It is a treat for us. You are the one who gets tired, sir. Thank you very much, sir. I think we'll close it now. Thank you, sir.